Hi, this is Brian Kim. I want to share with you this case of a patient who was referred for a dislocated IOL. He also had a small pupil. And so this was a 3-piece lens that was dislocated. I put iris hooks in to bring the lens piece up, and then I cut the lens in half. But instead of cutting it 90%, and I thought I was going to be able to get away with it, I cut it in half, took the first piece out, and then the second piece fell into the vitreous space. This is the first time this has ever happened to me. Hopefully it will be the last, and I certainly learned my lesson. The lesson is once the lens is into the anterior chamber, I really have to take the iris hooks out, or at least disengage it from the pupil to keep that lens in the anterior chamber, and then I can bisect the lens freely, or I can, again, use a Pac-Man technique. Nonetheless, I thought I lost this fragment. I called my retinal colleagues, planning for the patient needing a pars plana approach to remove the lens fragment. And lo and behold, I saw this patient about a month or two after his surgery during one of his post-op visits. And lo and behold, the fragment rose up and was actually within the pupillary opening. So I called this the Lazarus IOL fragment because he rose from the dead. Instead of being in the vitreous space, it was in the pupil. And so I was able to go ahead and perform the surgery. You can see the lens piece is still captured within the pupil. I had the patient take some pilocarpine. And with these Yamane cases, it's so important to dry the surface of the eye. So I use a Wexel sponge and make sure the eye is completely dry. And then I use a 27 gauge cannula, inking the tip. So I ink the tip of the cannula, inking the limbus on the right side. And then the left side, again, using the Wexel sponge, ensuring that the surface is completely dry, because I'm going to mark the conjunctiva, but it's supposed to reflect the intended scleral needle placement for those 30 gauge thin-walled needles for the Yamane technique. I use a cannula to find 180 degrees apart, and then I mark the limbus on the left side at the limbus in similar fashion. This is a fixed caliper from Epsilon. I have no financial interests. I'm indenting the sclera 2.5 millimeters posterior to that mark in radial fashion and 2 millimeters adjacent. You can see the indentations. I do the same thing on the left side in similar fashion, indenting 2.5 millimeters posterior to the limbus and then 2 millimeters adjacent. And then I use that pre-inked 27 gauge cannula, inking those indentations. Nice and discrete marks, which are very important when you want to get precise placement of the scleral needles. And this is a 1 millimeter paracentesis incision. I make one on the right side. This is a subincisional incision, which is going to be for the iris hooks. So I'm making incisions to help remove the lens piece, as well as my incisions for the iris hooks. You can see it's a really small pupil. And when you have a small pupil, it's really difficult to perform the Yamane technique because you have to have really good view. And a lot of your action of threading the haptics into the needle needs to be into the peripheral area, not central. Because if you try to do the manipulation central, you're going to be putting a lot of stress on those haptics. Making my contralateral limbal incision as well. This is some dispersive viscoelastic to coat the corneal endothelium. And remember, I've already done this surgery, so I'm making incisions in places that I already made incisions, namely this supratemporal 3 millimeter incision. Of course, I'm going to close it with a suture as well. After I make my incision, I quickly grasp that lens piece. I don't want it to fall. Grabbing it with forceps. And then grasping the haptic, switching the viscoelastic cannula for another forceps, and using a two-handed technique, carefully get that lens piece up. You can see there's some Sumrings ring attached to it, so I'm really a lucky guy here. Remember, I lost that lens fragment. I was really frustrated with myself and kind of bummed that it happened. It was the first time this ever happened to me, losing a lens fragment after I pulled that first fragment up. But you know, that's part of surgery. You got to learn your lessons along the way. You can see here Thankfully, that lens fragment has this giant Somring's ring kind of wrapped around it. So as I deliver that lens fragment up, I'm also trying to tease that Somring's ring out of the incision. Okay, so there's that lens piece out. And then I'm using viscoelastic to visco burp that last Somring's ring out. So again, pushing viscoelastic to fill the chamber, increasing intracameral pressure, and then burping the wound. I just don't want that piece to fall back into the vitreous space, so I'm just burping it. Gives me that extra reassurance. This is a 22 gauge thin-walled AC maintainer. It's small enough to go through a paracentesis, but provides excellent high infusion pressure. Using the cotton tip to control the eye, this is the 23 gauge pars plana trocar. I indent the sclera with the back end of it. I tunnel about 3 millimeters away, and I indent and then tunnel to that 3.5 millimeter mark. I turn vertical and I dive down. So that should be a self-sealing incision, hopefully, because you can see the trocar cannula is sitting slightly sideways, which means I have a good sclerotomy. And these are the iris hooks. Fairly straightforward technique. Slide it in and then rotate the hook down, catching the edge of the pupil and then cinching it down. No different from putting tension on when you're going fishing. You want to put tension when you have the fish's mouth on the hook. You want to set the hook. As you pull, it will catch the pupillary edge. Using the forceps to control the proximal end of the iris hook. Here's the subincisional one. Pulling the stopper back, rotating the hook, catching the pupil, retracting, and then cinching it down. So again, iris hooks are very versatile. You can customize titration and location. And this is why I like to use hooks in these cases. Doing some more vitrectomy, even though I did vitrectomy before, but just to be on the safe side. Remember, I had to kind of abort in the middle of the first case because I lost that lens piece. So I'm making sure I do vitrectomy in the area of the action, which is going to be where the marks are, to the right and to the left, where the scleral needles are going to be going. Okay, I'm bending my needles. This is 25 gauge needle mounted on a syringe of BSS. Push the BSS in, angle and bend the needle. Again, fairly close to the tip, facing to the right. This is the right side needle. I'm going to bend it 9 millimeters from the tip. The bevel is facing towards the main incision. And then the left side needle, again, mounted on BSS in the syringe. Push it through, bending it so that the bevel is facing towards a contralateral limbal incision. This is the Sensar IOL cartridge. This is the Emerald cartridge. This is the one that is used and designed for by Johnson & Johnson. Push some cohesive viscoelastic on the barrel, placing the Sensar AR40 lens on the platform, seating it down, making sure the optic is pushed all the way down before I start flexing the wings. When I flex the wings, I make sure that's right. You see I'm doing a little wiggle, pushing it so that the optic bends backwards, concave. The leading haptic goes through the barrel, and then the trailing haptic comes out through the back end. When I slide the cartridge into the injector, I make sure the trailing haptic is up and outside of the barrel. So when I advance the plunger, it doesn't damage that trailing haptic. Placing the 25 gauge needle through the contralateral limbal incision, having both bevels facing each other. My assistant starts to advance the lens. Because both bevels are facing each other, that leading haptic is able to dock very nicely on the bevel of the needle. I flatten it out, let it go in. As she advances it, more of the haptic goes into the needle. Once I pull the 25 gauge needle out of the eye, the leading haptic comes out, and then I take over, deliver the optic, and then make sure the trailing haptic comes out facing to the right. This is some dispersive viscoelastic to protect the cornea. Holding the trocar cannula with forceps, I have the right side 30 gauge thin wall needle, and I stab the conjunctiva and sclera at the first mark. I stab, turn on infusion, I flatten out, I stay basically parallel to the surface, go 2 millimeters, and then I dive down towards the optic nerve. I'm adjusting the lens. I'm making sure that more of the leading haptic is out to push the optic back away from me, sliding the trailing haptic into the incision. These are the non-toothed forceps. Dock the haptic on the bevel needle, flatten it out, 2 pushes, it's in. You only need 2 pushes. Don't push too much haptic into the needle. Disengage the needle from the syringe. And the reason why you don't want to push too much haptic into the needle is going to cause too much tension on the opposite optic haptic junction. Very important that you don't put too much of that haptic into the needle. Internalizing the leading haptic, placing it into the angle, holding the contralateral limbal incision with forceps, stabbing the first mark through the conjunctiva and sclera, flattening it out, being near perpendicular, tunneling 2 millimeters, and then diving down towards the optic nerve. These are the smooth forceps once again. I'm able to grasp the leading haptic, which is sitting in the angle. And again, you want to turn the needle towards the haptic, not the other way around. Dock the haptic on the bevel needle, which is able to secure it. Flatten it out, 2 pushes, and I'm in. I'm going to slightly pull both needles out, but not all the way, to keep the optic centered and to reduce any tension on the optic haptic junction. As I pull that left side needle out, I'm pulling towards me, and I'm minimizing how much of that haptic is externalized. By doing it that way, you're minimizing any tension on the opposing optic haptic junction. Holding the haptic with forceps, turning infusion off, drying the surface with a Weck-Cel sponge, and then cauterizing the tip. You can see that it melted the iris hook, but who cares? That's a single-use hook anyways. Doing the same thing, pulling the right side needle out away from me, and as I do this, I'm limiting how much of the haptic comes out. By doing this way, I'm able to limit how much traction is on the opposing optic haptic junction. Minimal stress on the haptic and the optic is a good idea when you're doing these techniques. And then drying the surface around the haptic and then cauterizing the tip. You can see this is not a flagpole sign. The haptics are nice and flat and they're symmetrical. Pushing the haptics into the sclera, opposing the conjunctiva, you can see a well-centered lens with minimal tilt because I have a nice scleral shelf on both sides. Taking the iris hooks out, pushing the stopper back, disengaging the pupil edge, rotating it, and then popping the hook out. Just keep doing this. Repeat, repeat. Very easy and efficient. Again, grasping, pulling the stopper back, bringing it some slack, disengaging the edge, and then pulling it out. This is the surgical PI using the vitrector. You can see low aspiration rate, low fixed cut rate. Don't place the cutter all the way into the angle. You don't want to do that. You might eat the ciliary body. Just place it where you can visualize it. And again, it makes a nice discrete mark. This is pars plana vitrectomy. I'm injecting some intracameral Kenalog. And as I'm doing vitrectomy, I'm able to clear the Kenalog. You can see there's absolutely no vitreous in the anterior chamber. Doing some more vitrectomy just to give myself extra reassurances and just to be on the safe side. But you can see a well-centered lens. And remember, you can have a decentered lens a little bit. It's not that big of a deal. But what's really, really important is you want to have a good lens that's parallel to iris plane. You need to have the lens parallel to iris plane. That's really going to determine the best refractive result, minimal induced cylinder. Place a tendonodon suture to close the main incision, hydrate my incisions, and so that's the end of the case. So again, this is the patient. Again, I cut the lens out. This small pupil, I had to use pupil retractors to get the lens piece up. What I should have done was disengage the iris hooks so that the pupil could come down, and that would have kept that lens in the antechamber. I could have also done a Pac-Man technique, cutting the lens about 90% and then pulling the lens piece out. Got the first piece out. Unfortunately, the second piece fell out. Again, this is the first time this has happened to me, and hopefully I'll never do that again. I was really kind of disappointed, contacted the retina colleagues, told them the situation. They were going to prep the patient for surgery after waiting a couple of months. Thankfully, waiting a couple of months was a blessing in disguise, because the lens resurrected like Lazarus, came back into the pupillary opening and presented itself to me like a gift, like a Christmas gift, right within the pupil on the post-op visit. I gave him some polycarpine to hold that lens in the anterior chamber, and then obviously I took him back to surgery, was able to get not only the lens piece out, but the giant sum rings ring that was there. It was very, very fortunate for me that things worked out well. Got the piece out, put iris hooks in. You can see excellent exposure when I did that. Again, remember, the haptics are very delicate with the AR40 lens. Never try to manipulate the haptic. Try to redirect the needle so it faces and it's parallel with the haptic itself. Use a concept of using the bevel to flatten the haptic on the bevel, sliding it in, which will help ensure that you're more parallel. Remember to externalize the leading haptic, which gives you a lot of advantage to be able to have much more room and access. And again, minimal traction on the trailing haptic. By externalizing the leading haptic, it allows you to push that optic into the contralateral angle, creates a lot more wiggle room and area so that you can very gently thread that trailing haptic through the right side needle. Fixate the left side needle. Again, very easy to do that one. Again, minimize externalizing of the leading haptic in order to minimize any stress on the opposing optic-haptic junction. Create small flanges. And you know you have a great lens position because you have no flagpole sign. You don't have the haptic sticking up towards you. If the haptic is sticking up towards you, that means you have poor scleral support, and that lens is going to sag backward. It's not going to be underneath that iris and parallel to iris planes. It can be tilting and sagging. And so that means you got to start over and do it again. You can see again in this case, fortunately, well executed, my modified Yamane technique using the Sensar AR40 lens in this Lazarus IOL fragment case. So I hope this was helpful to you, and I thank you for your attention.